I think. Okay. And okay. So continuing, we have anemia in acute kidney injury. I was doing malaria from a little bit time, but I did notice that my mobile was not recording. I've done most of the topics, only comb failure, yes, I couldn't do. I know about it, so I can write on my own a lot of different things. Let me just check one small thing. Genius volume. Genesis mesophila, orthophilia, DC provocation test in other fluids, radiologically classified fluidia, antigen detection, ELISA, PCR for DNA detection. It is topical pulmonary esophageal with the treatment to give diethyl carbamazine due to molecular intensity of reaction is there. Ivermectin kills only microfilaria, not the adult world. Doxycycline plus ivermectin single dose. Surgery in cases of established elephantiasis. Chronic lymphatic pathology, prevention of secondary infection. Tight bandaging, prevention of further damage, diagnosis and antibiotic therapy. Surgery, basic plastic surgery in established cases. Vital seals and cardiac can be repaired. Caused by Wuchereria pancrofti and Brugia malayi. And your blindness caused by losses by Laurova, but female mosquito tearing blood meal. Female Anopheles. Clinical features: fever, chills, sweat, headache, muscle pain, internal recurs several times in a year. Temporary edema, more persistent lesion in lymph nodes. Enlarged, painful, and tender. Inflammation is common. Chronic stage, you have development of permanent lymphedema, scrotal edema, pale everywhere. Hydrocele. And that's it. Fertilisis is more than enough. Take from nematode cystis, tedious volume. Toxanthic calcified cyst will be shown. CT also shows calcified cyst on small potential lesions. MRI is better. Serological test specific enzyme linked blood texts, histological examination of exercise, subcutaneous vision shows neurocysticercosis, albendazole, corticosteroid, parasequetal, antiepileptic drug, and operative intervention. That's it for now. Okay, so you're done with this one. Oh, you're not. Okay, psychiatry, geriatrics will do. Geriatrics is very easy. Psychiatry, I really don't think I have the time. I really wanted to do psychiatry, a lot of things, but I couldn't. Infectious diseases, of course. I'm doing it now. Acute kidney injury will be there, hypoglycemia will be there in malaria, fluid and electrolyte balance, hypovolemia, acetoic breathing, and lactic acidosis will be there. Non-cardiogenic pulmonary edema is there. Serious complication of severe pulmonary in adult. High mortality rate. Several days after antimalarial therapy, anti-immune patient is improving. Non-cardiogenic pulmonary edema, hyperparasitemia, renal failure, pregnancy, hypoglycemia, and lactic acidosis, aggravated by vigorous administration of IV fluid. Circulatory collapse, algae malaria, hypotension due to peripheral circulatory failure. Massive will be present in future in systolic blood pressure less than 80 mmHg in supine position. Less than 15 children. Cold, clammy cyanotic swell, constricted peripheral veins, and rapid febrile pulse. Often associated with complicated gram-negative septicemia. Sites of associated infection should be sought in patients. Surgical analysis is also observed. Average dehydration on gastrointestinal average dehydration, hypervolemia. Blood and urine culture should be done. Okay. Malaria, hemoglobin, black water fever, severe disease, G6PD deficiency, and other erythrocyte deficient may develop vascular hemolysis, hemoglobin treated with primaquine. Non-immune patient with chronic ulcer and malaria. Demonstration of asexual forms of parasite. Thin and thick smear should be examined by the suspected. Romanovsky sign. Leishman's or Bingham sustain. Bone marrow aspirate. And some patient with severe malaria infection. Plausible antimalarial. If they have been taking malarial treatment, you can take bone marrow aspirate. It's more sensitive. Alternative methods, you have dark field microscopy and benzothiocarbazepine, acryl orange and rondamine, acrylein orange and rondamine. 1, 2, 3. quantitative Buffy coat analysis alternative, more sensitive test than peripheral smear. Centrifuge Buffy coat is stained with a fluorochrome acridine orange, lights up with microtubule concentration. Methods with acryl orange staining, malaria parasites. The Buffy coat is viewed. The Buffy coat smear is viewed under fluorescence microscopy. Immunodiagnosis, serological techniques, which is immunofluorescent assay and enzyme-linked immunosorbent assay. We have PCR testing by PCR amplification of parasitic nucleoside for parasitic messenger molecule or DNA, RNA or DNA. More sensitive than microscope and rapid diagnostic testing. Rapid diagnostic testing. PFHRP2 tests, PFHR2 PMA and PELDH test. PFL serum, histidine-rich protein 2, pan-specific plasmodium, aldolase, parasitic like species in PFH82, parasitic LDH. PFHRP2 is only pulse serum, 4 species. This is not important. Okay, other blood refining blood, you have normochromic normocytic anemia and thrombocytopenia. TLC count is low, but neutrophil leukocytosis may be observed in severe infections. Acute phase protein ESR is high, plasma viscosity is high, CRP is also very high. Coagulation study, severe infection, prothrombin time, partial thromboplastin time may be prolonged. Other findings, you have low plasma concentration of glucose, bicarbonates, calcium, magnesium, and albumin, elevated level of lactate, BUN, creatine, muscle enzyme, bilirubin, and gamma globulin. Neuroemerging in cerebral malaria. Management or treatment, you have counter the threat of resistance of PFL serum to monotherapies, improve treatment with combination of anti-malarial drugs. So 2 or more blood cytocidal drugs you have to take. So you have artemisinin based combination therapy and non-artemisinin based combination therapy. Artemisinin, artesunate, arteether, artemethyl dihydroartemisinin produce rapidly runs of parasite anemia in combination with rapidly eliminated compounds, tetracycline, clindamycin, 7-day course. Non-artemisinin, you have sulfur dioxide, pyrimethamine with chloroquine, SPCQ, or amiodarone, SP plus CQ, whichever. Amiodarone. Artemisinin combination therapy is given in India is artesunate sulfonamide pyrimethamine. 200 mg artesunate sulfur dioxide 150 1500 of pyrimethamine and 200 mg artesunate on 213. Quinine salt 8 times a day for 5 days, single dose of sulfadoxine. Chemoprophylaxis, we have less than 6 weeks doxycycline, long term more than 6 weeks mifloquine, weekly, daily. 2 days before, 2 weeks before, 4 weeks after, 4 weeks after doing the area. ECTs can be given in 3rd and 2nd trimester, quinine in 1st trimester. Sensitivity is suspected imifloquine. Alternatively, dihydroartemisinin, piperacin. Of course, coma, you provide airway patient on the other side of coma. Corticosteroids. Hyperpyrexia, tepid sponging, convulsion. You have maintain airways, check glucose, hypoglycemia. Exploratory hypoglycemia. Topical splenomegaly is massive enlargement of spleen from abnormal immune response to repeated attacks of malaria. This is among residents of endemic areas of malaria. Chronic repeated malaria infection, hypergammaglobulinemia, normocytic chronic anemia, massive splenomegaly. Increase ratio of CD4-CD8, continuous IgM production, formation of hyoglobulins, stimulates reticular population and leads to splenomegaly. Clinical features: anemia, some degree of pancytopenia, respiratory and skin infections. Biopsy can be done. Sinusoidal lymphocytosis, Scuffed cell hyperplasia, IgM aggregate cells. Leukemia, thrombocytopenia, normocytic chronic anemia. Increased reticulocyte count. Malaria vaccines, pre-erythrocytic vaccine, erythrocytic and transmission blocking vaccine, all of these, and just mention it. Okay, so this entire thing is done. Geriatrics. I'll do geriatrics on my own. Leave it. Stroke. How big is this? Quite big. Quite big, yeah. Stroke I need to do, geriatrics I need to do, psychiatry I'm not touching you. I really don't think I can finish psychiatry. I'm thinking I'll do stroke. Running stroke, it's serious and epilepsy also, man. I finish our stroke, yeah. Geriatrics I'll do slowly. Respiratory system also I'll do a little bit slowly. Only revision is left. Okay, stroke is a cerebrovascular accident, syndrome of rapid abrupt onset of neurological deficit. It is rapidly developing clinical signs of focal or global disturbance of cerebral or disturbance lasting for 24 hours or longer, leading to death with no apparent causes other than vascular origin. Progressive stroke or stroke in evolution, in which focal neurological deficit worsens after patient first presents, increasing volume of infection, secondary hemorrhage, or increasing cerebral edema. Complete stroke is rapid onset, persistent deficit does not progress. Evolving stroke, gradual stepwise development of neurological deficit. So patient will develop slowly over weeks to months, unlikely to be due to stroke and suggestive of tumor and inflammation or degenerative if it is weeks to months. Transient ischemic attack is a transient attack, reversible ischemic deficit, and in some cases deficiency lasting more than 24 hours but resolve or completely become proper within a few days. Stuttering hemiplegia, repeated episode of TIA followed by fully evolved stroke. So types of stroke, you have ischemic stroke, hemorrhagic stroke, and cardiovascular anomalies. No, ischemic, hemorrhagic, that's it. Okay, so ischemic stroke is cerebral infection most commonly caused by thrombotic disease. Secondary to atherosclerosis, major extra carotid artery. 20% are caused by emboli from heart. 20% from thrombosis in situ due to intrinsic small perforating results produce lacunar infarcts. Intracranial hemorrhage caused by bleeding directly into or around the brain. Neurological symptoms produced by compression, toxic effects, or raised acidity. Cardiovascular anomalies such as intracranial aneurysm and atrial venous malformation. Ischemic stroke, hemorrhagic stroke, others. Ischemic is cryptogenic, cardiogenic emboli, others. Small penetrating artery thrombosis, lacunar stroke, large artery thrombosis, atherosclerotic disease. Hemorrhagic ischemic infection. Arterial dissection, venous thrombosis vasculitis, arterial venous malformation. Risk factors for stroke, high risk hypertension, smoking, diabetes, atrial fibrillation, cocaine, amphetamine, dilated cardiomyopathy, endocarditis, low risk, you have migraine, contraceptives or alcohol, and patent pheromone oil. In high risk only you have high cholesterol, obesity, vasculitis, systemic vasculitis. In low risk, recent MI, prostatic valve, sleep apnea. Additional risk factors common in young patient: protein C or hypercoagulable state, antithrombin 3 deficiency, antiphospholipid syndrome, factor 4 Leiden mutation, prothrombin, sickle cell anemia, hyperhomocystinuria, TTP, arterial dissection, infections, and systemic malignancy. So, in case of ischemic stroke, pathophysiology, it is complete stop of cerebral blood flow, causing death of tissue within 4 to 10 minutes. Ischemic core is less than 10 ml per 100 grams per minute. Ischemic penumbra is the region surrounding the central core. Tissue of penumbra is functionally impaired and at risk of infarction. Potential to be salvaged by revascularization is there. Damage is coupled by inflammation excited and mediated by glutamine and sodium. Also, hyperglycemia worsen the penumbra, so it needs to be controlled. Pathophysiology of embolus or thrombus. Hypoperfusion is there, ATP depletion is there, activation of lipid peroxidase, proteases, and no synthetases leads to fatty acid release. Activation of procoagulant pathways will be there, leading to again thrombus and embolus. But if activation of peroxidase, proteases, and no synthetase, there is destruction of intracellular organelles, cell membrane, and release of free radical, leading to liquefied necrosis. So, ischemic penumbra and ischemic core, you have black center. So, there is diffuse abnormality, blood flow less than 10 ml per 100 gram per minute, cytotoxic edema is a reversible ischemia is penumbra. Perfusion abnormality less than a little bit more. No, this is core. This is penumbra. Reversible ischemia is there. Okay. So, etiology, embolic occlusion may be there. Any vessel may be source of emboli, including the aortic arch, commonly internal carotid, vertebral, and basilar arteries. Atherosclerosis within the carotid artery, coronal bifida. Atherosclerosis is most common source of artery to artery embolus. In young, less than 60-year-old patient, intracranial atherosclerosis, dissection of internal carotid, vertebral arteries, or beyond the circle of this common source of embolic stroke. Cardioembolic stroke, heart is a common source of emboli, most often lodged in middle cerebral artery, posterior cerebral artery, one of the branches. Infrequently, anterior cerebral artery territory is involved. Non-rheumatic atrial fibrillation and other arrhythmias. Thrombus in the dilated left atrium is most common cause of cerebral embolism. Other causes include cardiac valvular lesions such as congenital valve disease, infective vegetation, rheumatic degeneration, calcific changes may cause embolization. Okay. Paradoxical emboli, atrial septal defect of patent pheromone oil allow the passage of fragments of thromboemboli from right atrium to the left. Most common causes of cryptogenic strokes. Fat embolism, mere embolism, amniotic fluid embolism, tumor embolism, rarely associated. So, thrombosis occlusion, large vessel thrombosis, site of rupture mural, thrombus plaque may produce occasional occlusion of involved vessels or may be a source of artery to artery embolism. Lacunar stroke is small vessel stroke, small penetrating artery, branches of 200 to 800 micrometer in diameter, supply the deep brain parenchyma. Each of these branches are occluded either by thrombotic disease or origin or development of occlusive vasculopathy. These thrombosis cause small infect named as lacules. Range in size from 0.2 to 15 mm in diameter. This factor include hypertension in age. Small vessel strokes account for 20% of all strokes. Symptoms is fluctuating symptoms, capsular warning syndrome. So symptoms, you have pure motor, contralateral hemiparesis or hemiplegia, affects face and leg equally. Like shared branches of medullary artery. Okay, pure sensory, you have contralateral hemisensory loss, persistent or transient numbness or tingling on one side of the body due to ventral posterior lateral nucleus of thalamus, like shared branches of MCA, small thalamoperforatus of PCA, mixed sensory motor, you have contralateral weakness and numbness, hemiparesis hemiplegia with ipsilateral sensory deficit, thalamus and adjacent posterior limb of capsule, like shared branches of MCA. Dysarthria, clumsy hand, slurred speech and weakness of contralateral hand, basilis pontilis, basilar artery perforatus, ataxia, hemiparesis, a combination of cerebral and motor symptoms will be there. Internal capsule, posterior limb, basilis pontilis, basal pontilis. Basically, if it is cerebral, it is basal pontilis, corona radiata, of course, and the internal posterior capsule of the limbs. Posterior capsule is mostly motor function, so makes sense. Vascular supply is straight branches of MCA. Most common affected branches MCA, you have to remember, and straight branches, you have to remember. Basilar artery for basilar pontilis, basilar artery, if it is cerebellar. I think this image is good. Yeah, you can see. Right, okay, leave it. Hemibalismus or hemicoria, ipsilateral, contralateral flaring and dyskinesis, subthalamic nucleus, anterior choroidal PCOM. Just a second. Just a second. Okay, so coming back, we have a little bit of clinical anatomical correlation, internal carotid artery, left anterior cerebral artery, right anterior middle cerebral artery, right middle cerebral artery. So yeah, anterior cerebral artery, middle cerebral artery will combine to form internal carotid artery. Ipsilateral molecular wall. So left side you have right leg numbness and weakness. Right side you have left side numbness and weakness. Transcortical motor aphasia, ideomotor aphasia will be there. Motor neglect and possible ideomotor apraxia may be there. Middle cerebral artery, you have right face and left leg numbness. Left face leg more than leg numbness and weakness. Then you have aphasia will be there in the left middle and left sided race preference. You have in the right middle cerebral artery, you have left hemifacial neglect and right sided gaze preference, agoraphasia, and acerognosia will be there. So, yeah, this is how you localize the stroke. Internal capsule where hemisensory loss, semianopia, Pons will be having hemiplegia, nerve lesions, and all. Spinal cord above L4, C4, you'll have hemiplegia, posterior columnar sensory loss, contralateral, ipsilateral posterior columnar sensory loss, contralateral pain and temperature loss, no cranial nerve involvement, and all is noticed. Cortex, you have hemiplegia, contralateral hemiplegia, contralateral upper motor nerve, seventh nerve palsy, apraxia, aphasia, apraxia, seizures. Midbrain, you'll be having contralateral hemiplegia, upper motor, contralateral upper motor nerve, seventh nerve palsy, ipsilateral ophthalmoplegia. So here you can see the difference. It is ipsilateral, here it is contralateral, and it is lower motor, here it is upper motor, seventh nerve palsy. Sixth nerve palsy will be there with or without. Here it is ophthalmoplegia will be there, ipsilateral ophthalmoplegia. Contralateral hemiplegia is common in all of them. Internal capsule, there is dense hemiplegia, that's it. In the contralateral and in all upper stuff, hemisensory loss will be there in internal capsule. In contralateral, hemianopia will be there. Homonymous hemianopia. Cerebellum and midbrain, you will be having like lateral and medial. Cerebellum and midbrain only is a little bit different. You will have lateral medullary syndrome, also known as Wallenberg syndrome, due to occlusion of the posterior internal cerebral artery. Toast can be done. Large artery, cardioembolism, small vessel occlusion, other determined etiology, stroke of undetermined etiology. So, hyperperfusion leads to generalized reduction in cerebral flow due to systemic hypotension, produces syncope. If it persists for longer duration, infarction of the border zone, watershed areas between major and posterior cerebral artery. If there is severe stenosis of proximal carotid vessels, more severe instances, global hypoxia ischemia causes widespread brain injury, cancellation of cognitive sequel that ensues hypoxic ischemic encephalopathy. Focal ischemia infection is usually by thrombus and cerebral vessels themselves. Carotid and vertebral artery dissection in 20% of the young. Stroke is due to dissemination of carotid or vertebral artery. sequel of trivial neck trauma or hyperextension most sometimes. In large extracranial vessels, it occurs penetration of blood into subintimal region of vessel wall. False lumen formation will be there. Symptoms will be having pain in the neck or face is a clue for diagnosis. Venous stroke is 1% of the strokes. Predisposing features include it may occur in pregnancy, hypocoagulable states, and thrombotic disorders of with dehydration or malignancy. Consequence, you have cortical infarction, seizures, and raised ICT. Investigations and diagnosis, you have neuroimaging, CT scans to identify extraparenchymal hemorrhage, neoplasm, sepsis, and other condition mimicking as stroke. Brain CT scans generally does not show any abnormality and may not be detectable reliably for 24 to 48 hours. Neuroimaging in stroke, you have acute right atrial ACA infarct, acute bilateral posterior cerebral artery infarct, and Anton syndrome, and you have right medullary syndrome, right lateral medullary syndrome. CT may fail to show small ischemic strokes in posterior fossa because of bone infarct. Small infarcts on the cortical surface may also be missed. MRI documents extent and location of infarction in all areas of brain, including posterior fossa and the cortical surface. MRI is less sensitive than CT in detecting acute bleeding. Diffusion weighted imaging and flare more sensitive for early brain infarct than standardized MR or CT. Can identify ischemic penumbra, and patients showing large regions of mismatch may be better candidates for acute revascularization. Non-invasively, you can do duplex ultrasound, CT angiography, or occasionally intra-arterial contrast radiography. Cardiac investigations, cardioembolism is only 20% of ischemic strokes. So, source of emboli include atrial fibrillation, prosthetic heart valves, or other valvular abnormalities, and in recent myocardial infarction. Clinical examination ECG helps in identifying the source of cardiac emboli. Cardiothoracic or transesophageal echocardiogram to confirm the source for or suspecting source. Okay. So determining diagnosis of stroke on simple as history and examination is fast. Face, arm, speech, time. Face, sudden weakness of the face. Arm, you cannot, one or both arms you cannot lift up properly. Speech is difficulty speaking and slurred speech will be there. And time, it is sooner the treatment started, better the outcome. That's it. Complications, cerebral edema, cardiac arrhythmias, MI, neurogenic chest injury, chest infection, seizures, deep vein thrombosis, pulmonary embolisms, pressure sores, urinary tract infection, GI bleeding, stress ulcers, constipation, painful shoulders and contracture, depression and anxiety. Differential diagnosis of stroke. Treatment of ischemic stroke, time is brain. So there is 6 categories. You have first IV thrombolysis, endovascular techniques, antithrombotic treatment, medical support, neuroprotection, and stroke centers and rehabilitation. So first you provide an IV thrombolysis, which is recombinant TPA within 3 hours of onset of symptoms. It reduces disability and mortality from ischemic stroke. Indications and contraindications are provided. So administration at the rate of 0.9 mg per kg plus clopidogrel. Randomized studies of unfractionated heparin, low molecular weight heparins or heparitinoids have shown no benefit in reduction of stroke mortality, stroke-related morbidity, early stroke recurrence, or stroke prognosis, except in the case of cerebral venous thrombosis. Avoid Apiximab. Aspirin you have to give. Aspirin is the only proper thing. Aspirin, clopidogrel. Recombinant TPA. Endovascular mechanical thrombectomy can be done. Anticoagulation, routine anticoagulation is high risk cardiogenic reembolization. TIS, hypercoagulable state is safe, it is there. Cerebral venous sinus thrombosis. Okay. Medical support, infection prevention, DVT prevention, subcutaneous heparin, pneumatic compression stockings. Others you have catheterization, rice tube and all, but they do say some avoid urinary catheterization for 2 hours, but after that you can. Maintenance of BP more than fever you have to treat with antipyretics and surface chlorine. Serum glucose kept at less than 110. Decreased ICT by water restriction and IV mannitol, glycerol, head and elevation. Hemicranectomy, craniotomy and temporal removal of part of skull. Marked reducer mortality. Control of ICP, intracranial pressure. In cerebral stroke, small amounts of cerebral edema can acutely increase ICP of directly compressing brainstem. Prophylactic suboccipital decompression of large cerebral infarcts before brainstem compression is very useful. Decompression is very useful. Okay. Statins, you have atorvastatin, rosuvastatin. Neuroprotection, you have drugs like magnesium, nimodipine, magnesium lubezol, basic fibroblastic growth factor, and acetylcholine. And rehabilitation, you have proper rehabilitation include early occupational, speech and physical therapy. Goal of rehabilitation: return the patient to home and maximize recovery. Use of restraint therapy: immobilizing the unaffected side, improve hemiparesis following stroke. Secondary prevention. So you have ABCD square criteria. Age more than 60, BP more than 110 by 90, unilateral weakness, speech disturbances, duration more than 30 minutes or less, more than 60 minutes or less than 60 minutes, and diabetes. These are all assessing the stroke risk. There is also a Chard's square score. Statins can be provided, antiplatelet agents, clopidogrel, aspirin, anticoagulation therapy. Chats 2 square is age, hypertension, congestive heart failure, diabetes, and 2 points for transient ischemic attack or stroke. Endovascular therapy can also be done mainly in angioplasty. So, causes of young stroke, you have cardiac, congenital heart disease, patent formalin, mixed edema, fibrillation, cardiomyopathy, myocarditis, etc. Surgery, endocarditis, prosthetic, hematological sickle cell anemia, iron deficiency anemia, polycythemia, hypercoagulous you have protein C and S deficiency, antiphospholipid antibody syndrome, APLA. Hyperhomocystinemia, leukemia, lymphoma, pregnancy exposed to treatment such as anabolic steroids and erythropoietic nephrotic diseases. Vascular, you have non-inflammatory aortic dissection secondary to connective tissue disorders like Ehlers-Danlos and Marfan, hypertension, vasculitis, migraine, cerebral autosomal dominant arthropathy. Inflammatory, you have Takayasu, giant cell arteritis, polyarteritis, polyarthritis nodosa, etc. Okay, no, a lot of the next topics, intracranial hemorrhage and transient ischemic hemorrhage and cervical is very much important. I just need to finish this. Okay, I need to finish this and I need to finish geriatrics and I'm done. And I want to revise blood hematuria full. I think I'll revise hemat full after AKD CKD. I think AKD CKD and hemat is the only thing which is remaining for me. Honestly, I think I will just revise. I'll do geriatrics and I'll revise everything else. Psychiatry, I'll see whatever I can remember. I'll write. Fine. So let's before going through hemorrhagic stroke, let's finish circle of Willis. So there's basilar artery, posterior cerebral artery, posterior communicating artery, internal carotid artery, anterior cerebral artery will be there, anterior communicating artery will be there, and this is middle cerebral artery. And most common is anterior cerebral artery. Aneurysm. Secular berry terminal internal carotid, middle cerebral artery bifurcation, top of basilar artery. Most common for all these things. And spontaneous rupture causes subarachnoid hemorrhage. Rate of rebleeding is there if aneurysm not obliterated. Annual risk is less than 10. This is the only important thing. Before I finish subarachnoid hemorrhage, intracranial hemorrhage and intracerebral subarachnoid subdural hematoma 10%. Extensive hypertensive intraparenchymal hemorrhage is there. Basal ganglia, putamen, hypothalamus pons, carotid bleeds are rare. Pontine hemorrhage is 3 P's: pinpoint pupil, hyperparesia, paralysis, quadriplegia. Prominent decerebrate rigidity and pinpoint pupils reacting to it. horizontal eye movements are evoked by head turning or by irrigation of ears with ice water. Primary versus secondary hemorrhage. Consequence of hemorrhage: you have immediate cessation of function. Mass effect will be there. Hemorrhage may expand over the first few minutes or hours. Produce a rim of cerebral edema. Now they can cause shift of the intracranial. You have reabsorption of hematoma if patient survives. Neoclinical features depend upon arterial territory is involved and size of the lesion. Rapid onset occurs over minutes. Most common presentation, you have weakness of face of arm, disturbance of speech, focal deficit of brain function, negative in character. Lesion in cerebral hemisphere is a lesion in brainstem or cerebellum hemisphere, and intracerebral hemorrhage is also noticed. Unilateral motor deficit is a high cerebral function or deficit such as aphasia or neglect visual field effects. But ataxia, diplopia, vertigo, bilateral weakness will be there, and severe headache and nausea on the onset of fever. Okay. Unilateral motor deficit, higher cerebral function deficit, aphasia or neglect or visual field defects. Brainstem or cerebellum, you have ataxia, diplopia, vertigo and bilateral weakness. Intracerebral hemorrhage, you have severe headache and vomiting at the onset of focal deficit. Management or treatment, you have any identifiable coagulopathies, VKAs, rapid reversal of coagulopathy achieved by infusion, prothrombin complex, administered quickly, followed by fresh frozen plasma and vitamin K. ICH associated with thrombocytopenia. Control of BP is more than 185 by 110. Increases the size of hematoma by more bleeding. Maintain MAP less than 130 mm per kg unless ICP is raised. Nicardipine, labetalol, esmolol can be used to decrease the BP. Hypolosmolar treatment, you have mannitol you have to provide, and hypertonic saline should be provided. Hyperventilation decreases partial pressure of oxygen, which can induce constriction of cerebral artery by alkalizing the CSF. Barbiturate coma is also there. Barbiturate is provided. Hypothermia steroids are given. Raised ICP, midline shift of structures, consequent ablation coma as well as CSF can be drained. Brief episode of neurological transient ischemic attacks are brief effects of neurological dysfunction which resolve completely after a brief period. Transient episode of neurological dysfunction caused by focal brain, spinal cord or renal ischemia without acute infection. It may herald a stroke. Hemiparesis, aphasia most common. Armachurax fungax, hemisensory loss, hemianopic visual loss, diplopia. Types of TIA, you have large artery low flow, embolic TIA, like TIA. Evidence of a source of emboli. Arterial fibrillation on the endocarditis recent MI. Underlying risk factor condition may be present. Treatment is have ABCD square done. Have 2 recent TIAs. Advice for secondary prevention of stroke. will be vomiting other symptoms. Bleeding. Carotid root supports diagnosis. It is possible. Nasal irritation is happened in these both. Early resolution is variable and it is possible. TIA is precedes stroke in these both. On waking up is thrombotic, rapid within seconds sufficient, maximum amount of it can occur anytime, sudden and often during sleep or early morning. Vomiting will be absent or occasional in both of them, and headache will be mild or absent. Here it is severe and prominent. Okay, so stroke is done. Demyelinating I wanted to do a little bit. Wanted to do seizures and epilepsy more, but honestly I'm just going to do what do you say? I think I'll just do AKD, CKD, and I'll do geriatrics, and I'll just revive meningitis also I need to do. CKD, meningitis, car. This also is car. Okay, so yeah, I'll end this now.